Hey guys, welcome back to my channel, The ENT Resident. Today we'll be continuing and finishing our series on otosclerosis. Today is part 3 where we discuss about the treatment of otosclerosis. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So we'll under treatment of otosclerosis, we'll discuss in what cases can we just observe the case without giving any medical management or any surgical management. Then we'll discuss what are the medical management options we have and where do we use it. And lastly, we'll also discuss about the surgical management of otosclerosis. So starting with conservative management where we do not do anything at all and just observe the patient. What are the indications where we can just observe the patient and not give any treatment options? Those are number one is if the disease is unilateral. If you remember, unilateral otosclerosis is only seen in about 15% cases, whereas majority, which is 85%, we see bilateral conductive hearing loss cases. Now, otosclerosis, where it is unilateral, and some bilateral conductive hearing loss cases where the hearing loss is within the 30 to 40 decibel range and it is not hampering the job performance of the patient. In these cases, we can just choose to observe without starting off any treatment. Second is if the patient is very young, and third is if the patient is refusing surgery, we can keep them under observation for a while. And we should follow up these patients once in every 6 to 12 months. Next is medical management. Now we have multiple options over here, starting with sodium fluoride. Now, sodium fluoride, what does it do? It has been seen that it fastens up the maturity of the active focus and it arrests any further cochlear hearing loss. Now, what is the mechanism of action behind this? Now, this itself can be your long question in theory where they ask about the mechanism of action of sodium fluoride in otosclerosis. So, we have four modes of action over here. Number one, very important, is that sodium fluoride is an inhibitor of osteoclastic activity. We studied in part 1 where we discussed about the disease. We saw that what happens here is there is increased osteoclastic activity and decreased osteoblastic activity occurring in otosclerosis. So sodium fluoride acts on this by inhibiting the osteoclastic activity. Thereby, because the destruction of the bone has reduced, it is stabilizing the bone turnover. Second mode of action is it leads to increased calcium deposition in the otosclerotic foci that is there, and therefore it reduces the bone remodeling happening. Third is there are some cytokines which get released from the bony remodeling that is occurring in otosclerosis. Now, these cytokines are responsible for causing sensory neural hearing loss sometimes. Now, what sodium fluoride does here is it has the potential to release or to inhibit the release of these cytokines, or rather reduce the release of these cytokines. Fourth mode of action is sodium fluoride has this anti-enzymatic action on the proteolytic enzymes, which are known to be cytotoxic on the cochlea, and these are also responsible for sensory neural hearing loss. So we are seeing we have four modes of action over here. Number one is that it inhibits osteoclastic activity. Second is it increases calcium deposition. Third is it inhibits the release of cytokines. And fourth is it has an anti-enzymatic action on cytotoxic proteolytic enzymes. These are the four mechanisms of action by which sodium fluoride helps in treatment of otosclerosis. Now, next we need to know how are we going to give it, what is the dosage of it required, and how do we follow up the patient. So sodium fluoride, it's very important here is that you have to remember to give it along with calcium as well as vitamin D3. The reason is so as to prevent the development of secondary hyperparathyroidism. Now, the dosage required over here is usually 40 to 50 mg daily along with 500 mg of vitamin D3. And how do we follow up these patients? We'll check for their hearing every 6 months, and if we are seeing that the progressive deterioration continues to happen, we can think about increasing the dosage. And when do we decide to stop the treatment? If after 2 years of complete treatment, we are seeing that the condition has stabilized or it has improved, in that case, we can go ahead with stopping the treatment. And after all of this, what are the cases that we consider sodium fluoride treatment for? Now, these are all the indications that we have. First is patients who have a surgically confirmed otosclerosis and who are showing progressive sensory neural hearing loss, which is disproportionate to the age of the patient. Second is patients who have pure sensory neural hearing loss and whose family history, age of onset, audiometric pattern, and good auditory discrimination indicates the possibility of the person having cochlear otosclerosis. In these cases, also, we'll try sodium fluoride treatment. Third is patients who have a radiological demonstration of the otosclerotic lesions in the cochlear capsule. In these cases, also, we'll start them on treatment. Fourth is if the patient has positive Schwartz sign. Now, what does positive Schwartz sign mean? It usually indicates a active focus of infection. And lastly, if patients are found to have an active focus at the time of operation, even post-operatively, we should prescribe them with sodium fluoride therapy for at least 2 years. So these are the 5 indications of using sodium fluoride in the treatment of otosclerosis. Now, moving on to the contraindications, there are certain cases where we should not be using sodium fluoride for treatment. Now, the contraindications are if there is chronic nephritis and nitrogen retention, chronic rheumatoid arthritis, in pregnancy and in lactating mothers, in children before their full skeletal growth has been completed, because we are adding in fluoride over here, in patients who are allergic to fluoride therapy, and lastly, patients who have skeletal fluorosis. These are our contraindications. So, this is all about sodium fluoride in respect to otosclerosis that you need to know. Moving on to our next one, our second medical management over here is bisphosphonates. Now, bisphosphonates, the way it works is it reduces the bony remodeling, and as such, just like fluoride, sodium fluoride, it can also offer benefit to patients who have otosclerosis. Now, it has been seen that the new third generation bisphosphonates, they are showing a reduction in the rate of progressive sensory neural hearing loss in the patients who have cochlear otosclerosis. But these drugs are still under investigation. It is not completely sure whether we should use it or not, but they have been shown to have some promise over here. So that's about bisphosphonates. Now, before we move on to surgery, there are some other conservative measures as well which can be used in otosclerosis. Number one is we can give the patient hearing aids. Now, who are the patients who we can prescribe hearing aids? Is if the patient has refused surgery or if they are unfit for surgery, we can give hearing aids as an effective alternative treatment. This is also used, hearing aids are also used as a primary treatment or in combination with surgery in cases like far advanced otosclerosis. I'll talk about far advanced otosclerosis in a little bit. By using hearing aids, we are basically avoiding the need for any cochlear implantation. So this is about hearing aids. The only one thing disadvantage over here is the cosmetic side of the thing, because if the patient is very young, then hearing aids may not be the best way to go for treatment in case of otosclerosis. Next is bone anchored hearing aid. Now, bone anchored hearing aid has also been proposed to be a method of managing otosclerosis in some situations. A specific benefit involved with this is that it does not produce the risk of a dead ear. In case when you're performing surgery like stapedectomy, there's always a very minor risk of the patient ending up with a dead ear. Whereas if you use bone anchored hearing aid, that risk disappears. So when we are seeing there is an only hearing ear with otosclerosis combined with the difficulty of using a conventional aid like a normal hearing aid or a post fenestration cavity, these would be the ideal candidates for using bone anchored hearing aid. Next is we have direct acoustic cochlear stimulation. Now, this device is of use in patients who have mixed hearing loss, where a successful stapedotomy alone would not be able to reduce the hearing loss without the use of a hearing aid. In these cases, who are having a mixed hearing loss, we can advise the patient to go for direct acoustic cochlear stimulation. This device consists of an active middle ear implant which gets attached to the stapes prosthesis. And this allows direct acoustic stimulation of the perilymph via the stapes prosthesis. If you look over here, this here is the stapes prosthesis, and then we have this direct acoustic stimulation device which is stimulating the perilymph via this stapes prosthesis. So that's all about our conservative management here, where we have discussed what are the cases where we just observe the patient, what are the cases where we use medical management is in, and what are the cases where we use different devices. Now, moving on to our next part, I was talking about far advanced otosclerosis. Now, what is this? These are patients with otosclerosis where the average air conduction is over 85 decibel and the bone conduction is unmeasurable due to the limits of the equipment that we are using for audiometry. Now, in these patients alone, we cannot use the conventional air conduction aids only. These will not help over here. So, in these patients, our three modes of treatment can be: first is we can either do a stapedectomy and give them subsequent conventional hearing aids. Second is we can take them up for cochlear implantation. And third is, as I was mentioning just now, we can use the direct acoustic cochlear stimulation device. These are the three ways we can manage a case of far advanced otosclerosis. And here we need to take a very careful history and detailed history so that we can distinguish these cases from a pure sensory neural hearing impairment. The clues over here will help us in diagnosing this is to look at the time scale of the hearing impairment, any family history, previous audiograms showing an airborne gap, normal speech, and CT evidence of cochlear otosclerosis. In these cases, cochlear implantation gives the best overall results. But however, cochlear implantation is very expensive, so many patients may not be able to afford it. So, in them, we can also perform a stapedotomy and give them conventional hearing aid. That can also be a good first line treatment. And in these cases, we can reserve cochlear implantation for cases of failure. And patients who have a preoperative speech discrimination of less than 30% and more severe changes on CT scanning and small airborne gaps, they worsen with stapedotomy and they should be considered for primary cochlear implantation. These are the cases who will be the most valuable patients to go for cochlear implantation directly instead of stapedotomy. Now we'll talk about stapes surgery. What are the different surgeries that we know? This is just a brief history of how stapes surgery evolved over a long period of time. In 1878, the first mobilization of stapes footplate was done without the ossicular chain reconstruction. In 1892, the term stapedectomy was termed, and in 1920, fenestration of lateral semicircular canal wall was done. Fenestration surgeries got started around this time. And by the time of 1970s, we have stapedotomy, and 1980s when laser stapedotomy came in. This is just a brief history just for some general knowledge over here. Now let's start into surgical treatment. Now, what are the indications of surgical treatment? Number one is if we are seeing a firmly fixed stapes. How do we find that? There are certain indications to it. One is if the hearing threshold of air conduction is 30 decibel or worse. If the airborne gap is minimum 15 decibel for the speech frequencies. There is a negative RINI for 256 and 512 Hz tuning fork, and the speech discrimination score is 60% or more. In these cases, we can see that there is a firmly fixed stapes, and this would be an indication to take surgery. Second is in cases of mixed profound hearing loss with sufficient speech discrimination. In these cases, stapedectomy would be easily able to improve the use of hearing aid postoperatively. Next, let's look at what are the contraindications of surgery. So, coming to contraindications, our first contraindication is if there is an associated Meniere's disease. Why is this seen as a contraindication? If we look at the image over here, we are able to see this is the saccule. And we can see in Meniere's disease, we usually have a distended saccule. So, you can see that this saccule is distended. So, it comes in very close proximity with the foot plate. So, now in these cases, if you go to perform stapedectomy or stapedotomy, you may end up causing more injury over here. So, an associated Meniere's disease is a contraindication in these cases. Second is in young children. So, in young children, we often see recurrent eustachian tube dysfunction. Now, this eustachian tube dysfunction can lead to displacement of the prosthesis that you place or even cause otitis media. So, and also, secondly, the growth of otosclerotic focus is faster in children, leading to reclosure of the oval window. So, these two are the reasons why young children are not an ideal candidate for surgery. Third is related to occupation and leisurely activities which predispose to barotrauma. For example, professional athletes or high construction workers, divers, or frequent air travelers. These are not ideal candidates because TP surgery has the risk to cause postoperative vertigo or dizziness, and this can interfere with the profession. Or if there is frequent air pressure changes happening, they can also end up damaging the hearing and causing severe vertigo. So, all of these occupations and these kind of activities are not an ideal candidate. Next contraindication is if the patient has only hearing here. As I was mentioning before, that stapedectomy has a very little chance, about 1% chance of developing a dead ear. So if the patient presents to you with the only hearing ear, we should rather go for more conservative management like hearing aid, etc., instead of taking them up for surgery. Next is patients who work in noisy environment. Now, after stapedectomy, usually patients would be very vulnerable to getting sensory neural hearing loss due to the noise trauma. So that's why these patients either you have to change their environment post-operatively, or they would not be ideal for surgery, and we can consider other treatment options. Some relative contraindications are like having otitis externa, tympanic membrane perforation, and exostosis. In these cases, we can just treat the condition first before we go to perform stapes surgery. Next is pregnancy. Now, pregnancy is also a time during which we avoid stapedectomy. And if there is any the need for a second side surgery, that is also quite controversial whether we should take these patients up or not. Why? Because the risk is there can be delayed bilateral cochlear impairment, and this impairment can end up occurring many years after you have performing the stapes surgery, but the risk is very low here. And lastly, active otosclerosis is also a contraindication. If you see the short sign, that means that there is active otosclerosis. In these cases, also, we should avoid surgery. So, these are all our contraindications and the indications to performing stapes surgery. Now, let's try to discuss what are the steps, how do we do this surgery, or what kind of anesthesia do we give, etc. So, starting with anesthesia, usually we can do this under both local as well as general anesthesia. The surgeon can make their own choice about this. General anesthesia has the advantage that it gives you some flexibility in case you encounter with some difficulties during the procedure or if some complication develops during the procedure. Hypotensive anesthesia is very useful here because this will help you in reducing the chances of bleeding. You can also give local anesthesia, it is also very well tolerated. Short acting intravenous analgesia and sedation may be given at the beginning of the surgery, and local infiltration of 1% lignocaine with 1 in 1 lakh adrenaline is also used as a local anesthetic. Next, moving on to the two approaches. So we have two approaches over here. One is the permeatal approach and the second is the endoral approach. Now, what are the steps of the surgery that we'll do in case of stapedotomy? Starting with our first step, first we'll have to give local infiltration in the area. Where will we give it? We'll give it in the ear canal, and we'll usually use 1% lignocaine with 1 in 1 lakh adrenaline to give the local infiltration over here. After that, the second step would be to obtain a tissue graft which will help us in covering the oval window. This tissue graft can either be a vein or temporalis fascia or perichondrium or fat, any of this. Next, once we have harvested our tissue, our next thing would be to give an incision. We usually give the Rosen's incision over here. I've discussed about the Rosen's incision in another video. You can check it out over there. So after we give Rosen's incision, our next step would be to raise the tympanomeatal flap and reflect it upward. You can see that this is the tympanomeatal flap and how we have reflected it forward to expose our field. Now, sometimes in certain cases, we see a posterior superior bony overhang which is obstructing your view of the stapes. When that is there, we need to remove about 2 to 4 millimeter of the posterior superior bony overhang, and this will help us in making an adequate exposure of the oval window, stapes, facial nerve canal, and the pyramid. So this, our view over here has to be completely seen. If there is any kind of overhang which is obstructing these structures, in that case we'll remove about 2 to 4 millimeter of it. Next is, here you can see this is the incus and this is the stapes, and this is the incudostapedial joint. So we'll divide the incudostapedial joint using a joint knife. Usually we'll introduce it from the posterior aspect of the joint and we'll move it anteriorly to divide it. This is done so that the stapedius tendon will reduce movement of the stapes suprastructure. So after we have divided the incudostapedial joint, our next step is to check for the mobility of all the ossicles. So we check all the mobility of the ossicles and reassess to make sure that the stapes is indeed fixed and that we are not missing out any other fixed ossicle, like for example having a fixed malleus. So we are checking for the mobility of all ossicles. Once we have confirmed that stapes is indeed fixed, in that case, next step would be to divide the stapedius tendon. You can see here, this is the neck of the stapes. This is where the stapedial tendon gets attached. So we'll divide the stapedius tendon using either a laser, scissor, or micro hook. After dividing the tendon, the stapes superstructure, leaving behind the foot plate, can now be removed by fracturing the crura. But we should make sure that we are doing it away from the facial nerve, and it is better if we first divide the posterior crust with a laser or a crurotomy scissor so as to reduce the risk of mobilizing the foot plate. So you can see we have removed the stapes superstructure now, which is this portion. Next step would be, now we have to measure the distance between the footplate and the incus. Why? This will give us understanding of what is the length of the prosthesis that we'll require now. How do we measure it? It is usually measured from the undersurface of the incus to the footplate. Now the functional length of the piston is taken from the upper surface of the lower half of the loop to the tip of the shaft. So this is what usually a prosthesis looks like. These are some examples. This is the first one is a Teflon piston. Second one is a platinum Teflon piston, and third one is a titanium Teflon piston. Now once we have measured the length of the piston, so for wire piston, the thickness of the loop material is very negligible. So that is not taken into account. But in case of a Teflon loop piston, the thickness of the loop material is about 0.5 millimeter. And this has to be taken into consideration when we are cutting the shaft. The prosthesis that we are selecting should be, this is very important, It should be 0.25 millimeter longer than the distance that we have measured between the undersurface of incus to the surface of the perilimb, so that it can allow sufficient penetration. Usually, we end up having a 4.25, 4.5, or an occasionally 4.75 prosthesis being selected. So now that we know the distance and we have selected the adequate prosthesis, our next step would be to perform the stapedotomy. Now, what is stapedotomy? It is basically making and opening a hole in the footplate of the stapes. What is the site of this? Usually, this is done at the junction of the middle and the inferior third of the central portion of the footplate. So, we put it in the center at the junction of the middle and the inferior third, where the distance between the underside of the footplate and membranous labyrinth is greatest. We can make the stapedotomy hole either with a laser or a microdrill or a handheld perforator. The perforation has to be slightly wider than the prosthesis itself so that we can easily place in the prosthesis. If we are using a 0.4 mm prosthesis, in that case we should make the perforation about 0.5 to 0.6 mm. And important to know here is the tighter this fit is, less need would be there to have a connective tissue seal to seal in the opening. However, we can also not make it too tight. In case we make it too tight, the hearing will not be adequate. It will be reduced because the movement of the prosthesis will get impaired. So it is important to have the perfect size of this stapedotomy hole so that it fits well. It is tight, but it is not too tight so that the hearing gets reduced because the piston is not moving anymore. Next step is we place the stapes piston through the stapes fenestra into the vestibule, and whatever gap is there, we use blood, fat, vein graft, or a connective tissue seal to place around this footplate perforation to try to seal it. There has been some evidence which suggests that thicker the oval window sealant, greater the lateralization of the prosthesis. This would imply that a vein graft, being very thin, would actually be the most suitable, followed by perichondrium, fat, and fascia. After we have sealed up the footplate perforation, next step would be the tympanomeatal flap that we had reflected forward. We bring it back and reposition it. So these were the steps of stapedotomy. And next is stapedectomy. Now, stapedectomy is slightly different from stapedotomy, but nowadays, stapedectomy is not the surgery of choice anymore. The approach is the same as that of stapedotomy. The only difference is that the whole footplate, or more typically the posterior third, is removed with the help of PICS, and the defect gets covered with connective tissue graft, most commonly a vein from the forearm, and then the prosthesis placed on the graft and suspended from the long process of incus. So that's about stapedectomy and stapedotomy. Nowadays, we prefer to do stapedotomy over stapedectomy. Next, let's talk about STAMP. Now, what is STAMP? STAMP is laser stapedotomy minus prosthesis procedure. This laser procedure, it was described by Silverstein, where he described that using a handheld laser probe to vaporize the anterior crus of the stapes and then perform a linear stapedotomy across the anterior third of the footplate. The stapes mobilizes if the otosclerosis is confined to only the anterior third of the footplate. And here, the Stapedius tendon is preserved. Why? Because it gives better speech discrimination in noisy environment and increased tolerance to high amplitude sound. So this is what laser stapedotomy minus prosthesis procedure is, or rather STAMP. Next is the use of laser in stapes surgery. More and more with advancements, laser has been introduced into stapes surgery, and it has been seen to be as effective as all the traditional techniques for closure of the airborne gap that we have. The usual lasers used here are either argon, KTP laser, CO2 laser, or erbium YAG laser. Now, CO2 laser has a very decreased risk of inner ear trauma, And erbium YAG laser also has a very limited thermal effect. So these are the reasons why we prefer these specific lasers in stapes surgery. Now, there are certain advantages to using laser in stapes surgery. For example, it improves the accuracy or the precision. Second, it avoids any trauma to the inner ear structures. Third, it lowers the incidence of having any floating foot plate. And it also has good hemostasis and good long term results. Next, what are some perioperative hazards that can happen in case of stapes surgery? What are some things that we should be aware about and be careful about? First, related to the surgical approach, as you're approaching through the external auditory canal, if there is a presence of an exostosis that can end up narrowing the external auditory canal and thus reduce your surgical field view. Second, sometimes tympanic membrane perforation may end up occurring during stapes surgery, but we do not need to be too worried about it. We can easily fix it by doing a meningeoplasty over here. Next, let's talk about some anatomical aspects. So, because we are going into the posterior aspect of the tympanic membrane through that, the posterior superior and the posterior inferior quadrant, the chorda tympani nerve is very close to this region. So, we have to make sure that we displace the chorda tympani nerve very gently from away from the operative field. Second is the presence of facial nerve close to the stapes. We have the vertical segment of the facial nerve which lies very close to the stapes. So sometimes the facial nerve canal can be dehiscent just above the oval window in about 10% cases. In these cases, we have to be very careful so as to so that the dehiscent nerve does not end up embedding in the fibrous tissue in case of revision surgeries. And the facial nerve canal can also sometimes overhang the stapes footplate, limiting the access that you have towards the stapes. So these are some anatomical factors that we need to consider. Third one is the presence of any other vascular anomaly which is major. For example, if there is an aberrant internal carotid artery, in that case, you should not proceed with the surgery. Second is if we have a persistent stapedial artery. The persistent stapedial artery usually runs from the facial canal between the two stapedial crura, and that can end up obstructing your surgical view, and this will cause troublesome bleeding. So, we should be very aware of a persistent stapedial artery as well. In case it is present, we can use a epinephrine soaked gel foam to shrink the stapes artery remnant. And we can place the fenestra, that is the stapedotomy hole that we are making, posterior to the presence of this artery without disturbing it. So we have to have these anatomical anomalies in our mind when we are going for the surgery. In case we do find them, how do we approach them? Next is ossicular problems. Now, ossicular problems can very easily arise as a complication of this surgery, or you can end up even finding ossicular problems even before you have attempted to do the surgery. For example, there can be a congenital or inflammatory fixation of the incus. There can be incus malleus fixation. There can even be malleus head fixation. So, these are all things you would have to look out for when you are performing the surgery. Next is osteogenesis imperfecta. This is a condition that has been associated with having poorer stapedectomy outcomes for otosclerosis. This is why is this so? Because this reflects the progressive mixed nature of the hearing impairment that has been associated with osteogenesis imperfecta. So therefore, we have worse outcomes if the patient has osteogenesis imperfecta versus a patient who does not have it. Next is moving on to the stapes footplate, where all our approach is concentrated on. So, perioperative difficulties here can increase the risk of causing sensory neural hearing loss over here. So, any minimal stapes fixation or a previous mobilization procedure can predispose the patient to developing a floating footplate. The first image over here, you can see this is a floating footplate. This can occur in less than 1% of the procedure. A preliminary burr hole in the footplate prior to fracturing the crura can reduce the risk of having a floating footplate. In 3 to 11% cases, footplate may be solid or it can be obliterated. The otosclerotic foci within the footplate itself can produce a very thick rice grain footplate. This has been associated with also an increased risk of floating footplate. Sometimes the oval window can also get extensively involved with newborn in case of a obliterative type of otosclerosis, which we are seeing on the right side. Next is cerebrospinal fluid gusher. This is very rarely happens. There is only a chance of about 0.03%. How will it present? It will present as this. You can see in the image over here, it will present as this rapid flow of fluid on entering the vestibule. This will be seen commonly in congenital mixed hearing impairment. Where does it originate from? It originates from an abnormally wide cochlear aqueduct or an internal auditory canal defect. So in these cases, how should we manage? We immediately need to position the patient so that their head is placed up than the rest of their body. And then after that, we can easily manage it with a tissue graft over the oval window with a prosthesis to anchor it. And sometimes we even need to use a lumbar drain over here. The operative field should be dry enough to prevent blood entering the oval window, and aspiration of blood or perillum from the oval window is seen to be very frequently associated with high frequency sensory neural hearing loss. So, this is a very rare hazard that may happen during the time of surgery, but if it does happen, we know now how to deal with it. Next, let's talk about the postoperative care and follow up of these patients. So, after surgery, we'll start them on analgesics and antibiotics if we feel the need of it. We'll advise the patient to avoid any kind of straining or blowing of the nose so that they do not end up displacing the piston. We have to, for usually, this can be done as an outpatient surgery and we can discharge within the few hours. First follow up should be the day after the surgery, and we can advise the patient to begin their office work 1 week after surgery. Second follow up should be about 2 weeks to about a month after surgery. And we should follow them up annually with Pureton audiometry. If there is a sensory neural hearing component as well, we can start the patient on sodium fluoride therapy. So that's about how we'll give postoperative care to these patients and follow them up. Next, let's look into what are some principal differences between stapedectomy and stapedotomy. Now, in stapedectomy, what we remove is we remove the footplate completely and then we seal it along with the prosthesis. Whereas in stapedotomy, we did not remove the footplate, whereas we just make a small fenestra in the footplate and put in the prosthesis through that. Looking at the energy transfer to the cochlea, stapedectomy shows a better low frequency hearing gain, whereas stapedotomy has been seen to show better results at around 4 kHz, meaning that they are giving a high frequency gain. Stapedectomy has overstimulation on the sensory apparatus. Excess energy can end up reaching the cochlea, leading to hair cell damage, whereas stapedotomy has a way less risk and way lower risk and lesser damage to the high frequency receptors. In stapedectomy, the risk of damage to the inner ear is more, and there is also more chances of prosthesis migration, whereas in stapedotomy, all of these chances are lesser. In stapedectomy, there can be a delayed sensory neural hearing loss, which can be about 9.5 decibel per decade, and the risk of immediate sensory neural hearing loss is about 1.5%. In stapedotomy, the risk of immediate sensory neural hearing loss is very, very low, almost negligible, and it can cause a delayed sensory neural hearing loss of about 3.5 decibel per decade. And lastly, complications are more in stapedectomy than stapedotomy, and that is the reason why stapedotomy has become more popular in recent times and the usage of stapedectomy has been reducing. Now, looking at the different techniques of stapedotomy, there has been no difference in outcome as such between the use of a micro drill and a handheld microperforator. And amongst the lasers that I was talking to you about, the KTP laser, CO2 laser, Orbium YAG laser, and argon laser, they have all been frequently used in stapes surgery. There are potential risks to the membranous labyrinth with the usage of lasers, which can be photothermal, photochemical, and photoacoustic damage. But if we perform the laser stapes surgery by using the right technique, in that case, the chances of damage is very low. And endoscopic stapes surgery is safe and has similar audiological outcomes compared to the microscopic surgeries. There has been some controversy seen on the aspect of whether we should preserve the stapedius tendon or not. The reason why we want to preserve the stapedius tendon is because it has been proposed as a method of preserving the blood supply to the long process of the incus. And preserving the tendon will reduce the discomfort that the patient will have at high sound levels, and it will also improve speech intelligibility of the patient. These are all the reasons why we should consider to preserve the stapedial tendon instead of cutting it. Next is revision surgery. Often we may end up needing to do a revision stapes surgery in a case of otosclerosis, but the revision surgery is associated with a greater risk of sensory neural hearing impairment and poorer hearing outcomes as compared to primary surgery. It has been advocated to use laser for revision surgery because you may end up in facing adhesions when you open your surgical field. So this will allow the adhesions to be cleared from the oval window to free and ankylose processes from the incus and to sculpture the incus and control its bleeding. Our last part of the topic on treatment of otosclerosis is cochlear implantation. I mentioned earlier there are certain cases where you need to do a cochlear implantation, one of them being far advanced otosclerosis. So let's look at what are the indications where we'll consider to do cochlear implantation. First is if the patient has profound bilateral sensory neural hearing loss. Second is in far advanced otosclerosis after they have failed surgery. Third is if we see no improvement at all with the usage of conventional hearing aids. In these cases, we will take the patient up for cochlear implantation. So that finishes our discussion on the treatment of otosclerosis. If you have any further question on this, please note them down in the comment section and I'll get back to you. Thank you.